All right, thanks everybody. My name is Bill Burdick, and I am Vice President for Education at FAIMER. And we are proud to be hosting and moderating this, this online discussion. This is a recorded conversation, so just to be aware of that. And this serves as a source of information for the Network Towards Unity for Health's Global Solutions Challenges. And those are challenges that try to address questions and seek solutions on issues like social accountability, interprofessional education, population health, and community approaches to engage rural and remote areas, migrants, refugees, indigenous, women, and elderly populations. So in the way of providing some context, the network focuses on universal access and equitable healthcare for all. And we try to build partnerships across the world with academic institutions, health systems, and communities, and try to serve as a global connector for these institutions. We try to create a coordinated collective repository of innovations and best practices and research that helps us to advance those goals. This conversation is a regional group of folks from North America, and we're doing this as part of our effort to build some regional community and to develop some regional consensus on approaches to some of these issues, all to serve the greater purpose of universal access and equitable healthcare. So on the line today, we have Margaret Tromp, who's the president of the Society of Rural Physicians of Canada. Good to have you, Margaret. And Keith Martin, who is the executive director for the Consortium of Universities for Global Health. Terrific to have you as well. And Aaron Alford, who's the director of research and evaluation for the National Network of Public Health Institutes. I hope I got all those introductions correct. I practiced. So it's terrific to have all you guys on. And what we'd like to do is ask each of the three of you to give us 3 to 5 minutes to introduce yourselves, to introduce us to your organizations, and to talk a bit about your work related to universal access and equitable care. And then we'll have some questions about North America alignment, about public health, and a little bit on reforming health systems. And then I'm sure we'll have questions from our chat. Maybe start with Margaret. Would you like to begin the program?
Thank you, Bill. So I'm a family doctor, and I work in Picton, which is a small town of 4,000 people, a catchment of about 20,000 people. Presently, I'm the president of the Society of Rural Physicians of Canada. And I'll talk a little bit about the society and a little about my community. So the society was formed about 25 years ago, and its mandate is to improve care for the rural population by supporting, educating rural physicians. So one of our traditionally big activities has been having a conference every year, which is education by physicians for physicians, and most of the people who present are rural family physicians, and they talk about topics that are relevant to other rural family physicians. We also have a behind-the-scenes advocacy role, working with lots of other medical organizations throughout Canada. One of our big projects right now is the Rural Roadmap Implementation Committee, which is a project we're working on initially with the College of Family Physicians of Canada, but now we have many other people involved as well. It's our feeling that there are many different players, so to make changes you need to have lots of different people involved. So for example, in our implementation committee, we have people from the Canadian Medical Association, from the Association of Municipalities, we have researchers, we have physician recruiters. That's just some examples. And we're all working together to see what we can do to improve physician services in rural communities. We're also on the Canadian Medical Forum, which is a group of 11 medical organizations across Canada, and we work with them on projects. I was just at the meeting yesterday for them, and one of the concerns presently there is how new technology is going to influence the provision of services. And as rural doctors, we do see some potential to provide services to isolated rural populations with the use of technology. For example, in Labrador, they have a system where they can participate in resuscitations and codes from a remote location. So this is a possibility for bringing services to rural populations. I'll just talk a little about when we're talking about promoting rural medicine. It starts, of course, at the very basic level of medical schools, and we have worked at having medical schools choose more rural students to attend. There is, this week, for example, I have a medical student with me for their community week. In the 3rd and 4th year, they have some rotations where students are exposed to rural medicine. So a lot of that has concentrated on the physician side of things. And of course, we know that the physician side is not the only side. And I think we're going to gradually work on including other professionals. At the local level here in Picton, I'm part of a family health team, and working with us, we have public health and legal services who share space with us. We also work very closely with social workers and home care and those types of services. So I think I'll just stop there for now in view of the 3-minute deadline.
That's terrific. Thank you so much, Margaret. And Keith, can I get you to talk a little bit about who you are and what you do?
Thank you very much, Bill, and welcome everybody to this webinar. As Bill mentioned, my name is Keith Martin. I'm the founding executive director of the Consortium of Universities for Global Health. We're about 1 kilometer north of the White House, or half a mile if you're in the United States, north of the White House here in Washington. And we work across research, education, service, and advocacy to improve the health of people and the planet. We opened up our doors here in September 2012. At that time, we had 53 members. Most of it was dominated by folks in the biomedical fields, particularly infectious diseases. But since that time, we have grown significantly. We're nearly quadruple our size. We're in more than 35 countries now. And our work, that research, education, service, and advocacy work we do, often is centered around our committees and their subcommittees. So those committees produce a number of products that can be useful to members, and they're all open access, such as toolkits, educational products. We do capacity building, particularly in low to middle income countries, global health programs we support, we do mentorship. So there's a lot of things that revolve around what CUGH does, and most of our members are in academia, but not exclusively. I think one of the things we've obviously focused on is really to try to make sure that our work is interdisciplinary. I think everybody on this call knows that we cannot deal with the big challenges we face. For example, what Bill mentioned, how do we get to universal health coverage? This is not a biomedical question, but this is a big challenge that requires the use of people in the biomedical and non-biomedical fields, and in an interdisciplinary way, and in fact across sectors. So at CUGH, that's what we do. And we convene people every year at our annual conference. We just had one in Chicago. Next year, and you're all invited to come, will be in Washington, D.C. Between the 17th and the 20th of April next year. And if you go to www.cugh2020.org, you can submit your abstracts and your panel suggestions for our conference. I really encourage you to do that. Share this widely, because we're also going to have a Hill Day on Capitol Hill on the 16th of April, where we will go to Capitol Hill and assert with congresspersons the importance of investing in and supporting global health programs. We also run workshops and webinars, and CUGH also is a sub on 3 programs. A STAR program, which trains fellows and interns. It's a USAID program. We also have a program with the Centers for Disease Control to strengthen public health capabilities amongst public health professionals. And finally, we have a Gates grant, and that grant is used to inform congresspersons, state representatives, and the public of the importance of investing in global health. But to get to the point, the central question that Bill asked, and I'll leave you with this. If you're going to achieve universal health coverage, that is a political choice. It's a political decision. And if you look at countries that don't have that, they've made a choice, or they don't have the capabilities of doing that. And particularly where there's greatest need, where there are fragile and failed states, every one of those states have something in common. They all have fractured, broken public institutions. So one of the central and neglected challenges in global health is, in fact, how we're able to strengthen public institutions so governments and institutions can have the people, the processes, and the resources to invest in and ensure that people, particularly those who are most marginalized, can access the health care they need. And at CUGH, of all the populations we focus on, we are most interested in improving health outcomes for those who are least privileged in this world. Personally, I'm a physician and a family doc, emergency medicine doc. I was a member of parliament. Like Margaret, I'm a Canadian, but I'm here in Washington. I was a member of parliament for almost 18 years in the House of Commons, and now lucky to be here in Washington working with great people around the world. I will say that beyond our membership of 189 institutions, we have important relationships with consortia around the world, including the African Forum for Research and Education and Health, 40 institutions there. We're working with the China Consortium, South Asia, our European colleagues, and our folks in the Asia-Pacific realm and in Latin America. So I'll stop there, Bill, and again, look forward to the discussions later on.
Terrific. Thank you so much, Keith. And Aaron, I'd like to hear from you.
Hi, I'm Aaron Alford. I'm Director of Research and Evaluation for the National Network of Public Health Institutes. We are a fundamentally domestic organization. We represent 40+ institutes across the country. Those institutes are designed to be 501c3 independent organizations, so nonprofits that are independent of the government, of any outside political influence. From there, they take on a lot of different flavors. We have some that are as small as 2 people, one that works in Appalachia that's very small, but then we have others that are very large organizations and look very commercial. Some are housed within universities, others completely standalone and own other organizations. One of our institutes owns 24 other organizations, some for-profit, some not-for-profit. These organizations tend to have mostly regional influence. As part of their founding charter, they have to be tied into either their state or regional public health infrastructure. Usually that means that there's a state director of public health is on their board. And they're designed to act as sort of an exoskeleton to the existing public health infrastructure. And so that can take on a lot of different flavors depending on what the local need is. Their funding is all over the map. Some are generating funding that looks very much like a hospital consulting, where their internal structures and the way they present themselves to the world looks very much like a consulting organization, whereas others are very typical old school public health not-for-profits that take in a lot of grant funding from foundations. Most of them receive funding from the CDC and otherwise. My role is to represent the research and evaluation capacity of that network. Overall, the network does about $1.5 billion worth of public health work annually. And so we need to be able to represent our capacity both internally as a group of organizations, but also externally to the federal government, to regional government, and to other stakeholders, including foundations and commercial partners. The work that is being done within this network very frequently is focused on populations that are fragile or challenged. We have a very strong health equity lens throughout the network that's in keeping with public health here in the U.S. Very much focused on the social determinants of health and that evolving philosophy and some of the ideas that are coming to ground there. As a network, we are a loose association of companies. We try our best to represent those companies, their interests, and then the interests of their constituencies through advocacy, national convenings, and as a part of that structure, we can make that available to the federal government and to other agencies that want to make use of that pulpit. So, for example, NNPHI is the home of the National Convening on Tobacco or Health, which is has seed funding from CDC, but then also funding from lots of other entities, which is a large convening that brings in folks that are concerned about the impacts of tobacco in the United States. We also have a second network that is based on funding from HRSA. It's called the Public Health Learning Network, and it's comprised of 10 regional public health training centers and then 40 other hyper-local centers that are used to push out public health training and also to drive up needs assessments from each of those regions. With that, I'll give back the balance of my time. Thanks.
That's great. Thank you very much, Aaron. So across all three panelists, we certainly heard loud and clear the notion of interdisciplinary, intersectoral, and bringing together connection between organizations. I learned a couple of new words from Aaron. I love that exoskeleton concept of that you mentioned, and the hyperlocal notion. So the question I would offer to you now is, how in North America are we operationalizing that sort of intersectoral and interdisciplinary idea and or goal? How do we? What are some of the ways in which we're doing that work? Margaret?
I think we're still at relatively early stages, but I think we're aware that many different disciplines are contributing, and we're starting to work together. So Ontario, where I work, has a model of family health teams, which are interprofessional. And as an example, in my practice, if I have a patient who is high needs, often a frail elderly at home person, I share that patient with a nurse practitioner who assists with a lot of the more social things, home visits, that type of thing, but because of their medical background, they can also assist with the medical care. So we have that type of thing. As far as intersectoral, we work with public health, and we work with community legal services, yes, and have them working in our space so that we can refer patients back and forth. So I think it is coming. I think it still needs a lot of work. I think that there are still quite a few people who are comfortable in their own office with their own space, and you know, I think it's going to take a little while before everyone's comfortable with this type of thing, but I think we're moving in the right direction. Thank you,
Margaret. Keith, any thoughts on this one?
Yeah, but there are a few things. So what we're doing is this is a compelling challenge, as Margaret said. siloed terribly across different disciplines. We can't address the challenges without working in an interdisciplinary way. So at CUGH, our education teams are working to bring different disciplines together, particularly the non-biomedical disciplines. We encourage at our conference to make sure that there are biomedical and non-biomedical disciplines represented on our panels around specific issues. But quite frankly, if we're really going to make a big difference, we started education, but we need to change the criteria for tenure. We need to reward in the tenure, the criteria for promotion within academia. We need to reward people who are working on bringing in different disciplines, being rewarded for changing their curricula, being rewarded for creating mechanisms for training and service. I'll leave you with one example. Very innovative work where senior dentistry students are actually going into low-income communities to provide oral health care to communities that would never get access to dental care. But how they got entry into those communities was through their pets, by bringing in veterinary students to provide vet care for those pets. People love their animals. So imagine this, you're actually getting dentistry and veterinary students together under supervision to provide care to communities that wouldn't do it. And in the process, they're learning new ways of global health, of One Health. That's a One Health issue dealing with a number of compelling public health challenges. So you can take out dentistry and veterinary sciences and put it nursing and medicine and law and other skill sets that would enable universities to provide training, research, as well as service opportunities.
Fascinating concepts. Thank you. Aaron, any thoughts on this?
So I'm always humbled by my colleagues from Canada. Our system has a lot of challenges by design, but we've been working with the Robert Wood Johnson Foundation on a project called State Forums to Advance Health Systems Transformation. And the whole premise is to use our network of public health institutes to start a conversation at the local or regional level about what the social determinants of health look like in their region, and then carry out that conversation using our public health institutes as sort of neutral conveners. And the idea was to get as many different industries and stakeholders at the table as possible to define what population health means locally. Because what we found is that if you go to a given discipline, the conversation gets pretty constricted pretty quickly because we all bring our own lens to it and focus. The moment that we have more stakeholders at the table, that population health definition really starts to take on a local flavor. And the only way that we found to be effective is to have as many stakeholders regionally at the table as possible. And so that, that ranges from local hospitals, local caregivers, across to public health. And then, of course, you have to have the patients at the table too, right? Because they bring their own perspective to it.
It's one thing to start these relationships. What about the issue of sustaining them? I mean, we've often had the circumstance of bringing different partners together. What is it that sustains these types of partnerships? Margaret, do you want to take a shot at the sustainability challenge?
Yes, I think from a very practical level, I think partnerships are easier to sustain if you're co-located and you're intermingling and seeing each other on a regular basis, and you're maybe sharing the lunchroom or sharing coffee hour or whatever. You have to get to know the other partners as individuals, as people, and not just as professionals. And so I think in places where they're able to do that, then things are sustained. When people are physically far away from each other, I think it's a lot harder. That's an initial suggestion. I'll leave it for someone else now to add.
Anyone else want to add on that one?
I mean, that's a very big challenge. I think both Aaron and Margaret have mentioned this in some ways, but I think that you have to have common goals. Those goals have to be impactful. You need timelines, you need discrete timelines. People are not going to get together, and you're never going to sustain. You're not going to sustain anything if the goals are diffuse and you don't get buy-in from everybody. So if the more discrete, the more impactful you have, the timelines you have with strong leadership and agreed common goals, and the agreed resources to back it up. And the resources need to be put in by the people who are part of this. If you have skin in the game, you're going to probably have a better chance of seeing it through. So if you have at least that going for you, then you have a greater chance of sustaining your partnership.
Aaron, any thoughts?
Well, our organization does not represent people. Fundamentally, we represent organizations made of people who then try and help the health of people. And so that may color my answer here. But what we have found in this very difficult space is that if we open with the language that we are partnering with the understanding that there is a business aspect to this, we are all looking to impact health in a positive way. And that's, we're mission driven, but there's also a business development aspect to this. And so across our organizations and across our partners, I personally find that being frank and open about that we do need to pursue funding, and that we need to organize the structure of the team with the understanding that business development is a feature there, and the sustainability is reliant on dollars. Frankness very often in that focus helps us to structure our work and our mission-driven work in such a way that we're also creating communications products that are not just focused on caregivers, but also focused on legislators, funding organizations, because those folks, not only do they want to see an impact, but they also want to be communicated with, right? And so when we structure our work, our mission-driven work, when we, as a team of organizations, decide that communications and business development are a part of that, it really increases our capacity for sustainability.
Very interesting thoughts. Let me give you a question that we've got from one of our participants in Egypt. Samar Ahmed has a question, and that is, what are the venues for funding that are encouraging for interprofessional development? And what amount of support is being offered to regional programs? So funding for interprofessional development. Margaret, you want to take a crack at that one?
Well, I will say that, yes, specifically for interprofessional funding, I do not have too much experience in this. What we've done interprofessionally, we've just had to fund it ourselves so far through our membership fees. So I know that's not the answer people are looking for there.
Keith, any thoughts on that one?
Since Ahmed is in Egypt, I would look at some of the Gulf states in terms of some of their large foundations that they're supporting. Ahmed would know that some of them are very interested in advancing regional educational opportunities. I would certainly pursue that. The other one is to look at the Wellcome Trust. They've been quite innovative and creative and open to exploring different opportunities, and this could be one of them.
Thank you. And Aaron, any thoughts?
Well, I can't speak to Ahmed's particular situation. I mean, here in the U.S., the federal government has made significant investments in the public health learning network that I mentioned earlier. And what we have found is that despite the fact that we are fundamentally focused on public health learners, that by making that freely available to anyone who wants to basically sign in and provide some basic information, that we have people from many disciplines showing up and from many levels within given organizations. So trainings that might be fundamentally focused at public health nurses we're finding that we're having doctors, dentists, receptionists showing up to that training. And so for us, the federal investments have driven that intersectoral capacity.
Thanks. Another question on the chat is the issue and the interplay between public health and medicine. The two disciplines seem to have fractured in maybe the 1920s or 30s when we discovered antibiotics and we didn't need public health anymore because everything was going to be fixed by penicillin. Thoughts from the panelists on mending that fracture and the relationship between public health and medicine? Maybe, Aaron, you want to start with that one since you look like you got something in mind.
Yeah, well, I have to admit, I've been in public health my whole professional career, so I may not be the best person there to answer that, but I can just speak to what I've seen in our network. We have found in our network of institutes that in public health, we have spent a lot of time, because of the structure of public health in our country, bringing partners to the table and creating these sort of neutral spaces with good facilitation where everybody can have a voice. And so now what we're finding is that the medical, if you'll forgive me for saying industry, in some of our regions is now using that capacity when they want to understand what needs to happen in their community, what the needs are in their community, what the voices in their community are saying. They're turning to our public health institutes as neutral conveners and facilitators to start that conversation, and particularly when it comes to community health improvement plans and needs assessments, community health needs assessments here in the U.S. A lot of hospital systems have been struggling with those, and so they've turned to public health. And I think it's really created a nice space where public health and sort of the medical infrastructure of the U.S. can sit down and have a conversation. But we're in very early stages of that. We'll see how that turns out. I don't know that there's any solutions there yet.
Bill, can I pipe in on this? This is such an important question. I think as many of the folks online right now know that 70% of deaths are due to non-communicable diseases. Public health is the most important engine to address those through prevention. Yet, in official development assistance for health, public health gets less than 5% of the funds. And through funding agencies that are investing in global health, public health gets the runt of the litter in terms of funding. So this is topsy-turvy. We have a sickness funding mechanism in global health, not a prevention and a public health funding mechanism, despite the fact that NCDs are the lion's share of death and disability on this planet, getting worse, and particularly getting worse in low to middle income countries, hitting them harder, younger, and in a more lethal fashion. So this is our collective job to start to change that, to fight for to advocate for the investments that must get into public health. And that includes in the training, through advocacy, through research and education. Now, at CUGH, what we've done is we brought together our colleagues at the Association of Schools and Programs in Public Health. We're working very effectively with Laura McGunn at their head and their teams with us to be able to bridge that gap. And they worked with us to put together, in fact, a competencies toolkit in global health, investing a lot in integrating public health into that. So we're also working with our colleagues at ASPHER, which are the European version of the public health schools. So at CUGH, we're working with the schools and programs in the US, in Europe, and others to try to bridge that gap.
If I may, I really like the way you frame that. And this conversation about funding and about the various disciplines that are involved here, having a conversation is really key when we start to talk about the social determinants of health. Because when you start talking about those upstream determinants, we're going to have everybody at the table, right? You can't go into a doctor's office and prescribe something there. You can't go into a public health nurse's office and get an inoculation for the social determinants of health. These are really upstream functions where we have to have everybody at the table. pulling in the same direction.
I think, Aaron, your point about a rate of return and in bringing in the private sector and others is going to be really important, because what's interesting, back in Canada when I was in Parliament, I asked the head of the executives of all of the big companies what was their greatest concern, and you know what they said? Mental health. The leading cause of disability in the world. They said, look, we're not physicians. We don't know how to deal with this. But as the private sector, as chief executives of big companies, what we need to work on with you and others is we need to figure out how to deal with the huge impact that mental health is having on our companies and our workers. So that's just one example to your point.
Yeah, thank you. Margaret, any thoughts?
Yes. Trevor Hancock, who I'm sure we're all very familiar with, wrote an article a little while ago talking about where is the Ministry of Health really, and it's not in the Ministry of Health, it's in the Ministry of Housing, in the Ministry of Community Services, and the Ministry of... So I think when we talk about public health and broaden it out, it's really very broad, and it's in all areas of society and all areas of government. I agree that we are putting a lot of our money into acute care, and the healthcare budget is going up in Canada all the time, and the money comes from other ministries like education and roads and communities and whatever. So I think the two have to work very closely together. Now, how do we get that? I mean, I think in small towns, it's perhaps a little bit easier to bring these together. But I think the challenge is, as we define health as being, well-being involves every aspect of our life. And when we're looking at the social determinants of health, it involves every ministry and every segment of the population.
Great points, everyone. How do we go about engaging these non-health sectors? Engineering, housing, urban design, even the education system. Where's the leverage point? Where's the connector? You want to tackle that one?
I'm not sure if I have an answer straight off, but one of my concerns about concentrating on the business model is the business model is about making money, and a lot of these sectors, maybe there is a way that we can help the social determinants of health and still come out ahead financially, but I think that is going to be a challenge. I think what is happening right now, we know that the way income is divided right now is the poor people get very little money and the rich people get a lot, and the top 1% or the top 0.1% or whatever that might be. In order to give the segment of the population that is not doing well their fair share, I think it's going to cost us money, and I'm not sure where the profit's going to be there.
So, but Margaret, I want to just add on to that for a second, and let me look at a different community. Let me look at the political community for a moment. So we know that we can talk to the health ministers all we want, but if you really want to have traction, you speak to the Minister of Finance, you speak to the people who advise the President or Prime Minister. You need to understand where the levers of power are, and what you need to give to those folks is you need to give them the rate of return. They've got, multiple competing interests with a limited pot of fund. What we don't do a good enough job doing is expressing to political leaders at a federal, provincial, and at a local level, and importantly at a local level, what they can do with the public to actually prevent problems, particularly in public health. But we need to show the rate of return to them in terms of how their money can be used more wisely, and that's something they can take to the public. So when you go to the politicos, they want to know, what are you asking me to do? Why should I do this? What is it going to cost? And what is the rate of return on this? And you can define that rate of return quite broadly. But we don't speak to politicians in a language, I think, that they understand, because their incentives are different from those of us who are in academia, for sure. and maybe a little, maybe less so, of course, in the civil society world. But we need to bridge that gap. And finally, Bill, the challenge we found in engaging the non-biomedical folks is having the health word in global health. They think it's a bunch of doctors and nurses and public health folks dealing with this. And our challenge is to say, no, we need people, as you said, in engineering. We need individuals in the social scientists and the anthropologists and the economists and the veterinarians and others in what we're doing. But it's our job, I think, to assert that with them, bring them in and create platforms where they can engage the medical community. And there are not enough of those opportunities.
It's almost like we need to be using the words not only wellness, but productivity. Yeah, so there's another comment from the chat, and that is that there's often the concern with private sector funding of conflict of interest. And how do we address that issue of conflict of interest when we're engaging the business community and other private financial interests? Aaron, you're smiling.
Well, I mean, I can only speak to what our institutes as businesses, they're nonprofits, but they are businesses, right? They have a bottom line. So all I can speak to is that. And I feel like for a lot of folks, this is an uncomfortable space. But we regularly engage businesses of all types, be they nonprofit organizations or commercial enterprises, gainfully to impact health. And a lot of those organizations have their own motives, and that's okay. I think that's just the world we live in, and that's all right. But the one thing we have not done, and I didn't make this policy for our company, but I do value it, is that we don't deal with big tobacco, we don't deal with firearms organizations, and we don't deal with alcohol organizations, right? Because these are commercial enterprises that for which we don't feel that we can manage the conflict. But for everybody else, I feel like it's been fairly easy to open a conversation and say, this is what we bring to the table. These are our biases, etc. What do you bring to the table? And then to negotiate from there.
Thank you. Margaret, any thoughts on that one?
I'm just thinking a little bit. I mean, as far as conflict of interest, I think the biggest thing of conflict of interest is to declare it so that you know there's a potential conflict and that everyone's aware of it, and then it goes into your judgments or your decisions. But yes, I don't think there's a problem with having conflicts in itself. I mean, I'd be interested in hearing some practical examples where for profit, I mean, companies that are not for profit, I think that's a different situation. But for profit companies, I'm not sure how they are significantly involved in this, because I still sort of have this feeling in my soul that, you know, with the maldistribution of wealth, what we're doing in a certain way is we're redistributing it through whatever, by using government grants or whatever, we're redistributing wealth in some way so that the poorer people get services, and most of the for-profit companies are trying to accumulate wealth. So I see a sort of a problem there, how those two would work together.
And Keith, any thoughts on that one?
Just I think that as was mentioned before by both Aaron and Margaret, you can manage. I think you need to manage the conflict, and you can set parameters around which you can do that. But I think it is critically important that all sectors be involved. I don't think you can exclude any sector. We do that to our detriment. But I think it's just knowing what their goals are and what your goals are. You can find accommodations to make sure that you're moving forward in an ethical fashion. Healthy populations help the private sector, the public sector, and others. It is not in any sector's interest to have an unhealthy, unwell, public.
All right. There was another comment on the chat that logic doesn't necessarily move things forward. It's more about relationships and people. Any reaction to that comment?
I agree completely. I think that this is why I think co-location and things along that line are really important in all these areas. I mean, we can sit and chat, but until we really meet people, I mean, now that we have Zoom and we can see people's faces, I think it helps a little bit, but it's the real in-person meetings that I think make the difference for establishing relationships, and then they can be maintained by these types of methods. But yes, I agree, you have to have a relationship to move things forward.
And in addition, I'd say that you also, in communicating, I think it's important for us to know that it's even more important to actually affect people's heart than their mind. Sometimes in academia, we think that our logical arguments are going to win the day. They're not. People are going to work on, we know how people operate now. We have a better understanding people's fears, hopes, aspirations, concerns, whether they be logical or not, are really driving a lot of behavior. So if you're going to actually be politically effective, it's important to understand those. It's important to address those fears and concerns in very practical ways. And it's important to be able to not only let people communicate so they understand things in their mind, but more importantly in their heart. And a way to do that is we've got to tell stories. We've got to tell stories to get our messages across in very simple, effective ways. And unless we do that, we're not going to be able to be effective advocates.
Thank you. Aaron, any thoughts on that one? Logic versus personal relationships?
Yeah, well, I believe that personal relationships drive much more than logic does. Keith has said he's in the District of Columbia as well, and that's where I'm headquartered. And there's sort of a story that goes around about, if you have a chance to go to Congress or a tier, you always take the tier, right? I mean, it's the teary eye that gets the attention. And so in a lot of the work that we've been doing lately, as part of establishing our analytics, our evaluation designs, our research, we have gone to having a component, all of our evaluation plans and our work plans to be either a storytelling component or a case study. And now CDC actually is asking us to bring what they call success stories. And the idea being that you can build all the charts in the world, but at some point it's got to be one person sitting down with one other person and telling them a story that connects to them in a human way. Bring all the logic to the table you want, but if you can't have that human connection, you're not going to sway anybody.
Spoken as a program evaluator.
Yes, very much so.
Yeah, I think the notion of storytelling is pretty important, and I don't think we necessarily do it enough. But I think what you're hearing from these leaders from North America and in the area of wellness and social accountability is this notion that to be a connector and to be a leader in this domain is not just about facts and logic, but it's about telling stories that engage people on a personal level. As Margaret pointed out, it's nothing like a face-to-face meeting, although we are trying with video conferencing to make that a little bit of a closer connection. Those are great points. I'm just looking at the chat to see if I've missed any comment. I'm just seeing telling stories to address the limbic system. Okay, that's critical. Good. And let me just ask each one if they have any closing thoughts as we approach the hour here. Just to wrap things up from your perspective, the highlights of some of the things that we've talked about, and take-home messages that you'd like to be sure that that our audience perceives. Maybe I'll start with you, Margaret.
Yes, unfortunately, I forget the author of this, but I went to a webinar about change from a fellow who was from the Netherlands a few years ago, and they were asking him about, you know, what his thoughts were of being in trying to change things over so many years. And I remember him saying, more or less, change rarely comes in leaps and bounds, but from continually pushing in the same direction so that things are gently nudged along. And I think as we're looking at change, that's something that we have to keep in mind.
Terrific, wonderful thought. Thank you. Keith, any final thoughts for our global audience?
Just to thank you very much, Bill. It was great to be here with Margaret and Aaron. But just to all the people on the audience, the public can move the political, and it's vitally important that we engage the public about what is necessary to, as this webinar was about, health equity, population health, and achieving universal health coverage and better health outcomes. That will only happen unless we engage the public, and the public moves the political. So let's not forget that both policymakers and the public being even more important, is the route to change.
Terrific, wonderful thoughts. Thank you. Aaron, any final thoughts?
Well, it's been lovely to be a part of this conversation. Appreciate the invitations. Margaret, Keith, lovely hearing what your thoughts on this. For those listening, I would say, you know, the place for all of us to start is to have a conversation, and to bring everybody to the table, you know, that you possibly can. And so in that spirit, I'd love to, you know, if anybody wants to connect, would be happy to connect and continue the conversation offline. And if there's any way that, you know, the National Networks of Public Health or any of our members can be useful in facilitating a conversation, we'd love to be a part of that.
That's wonderful. Thank you. As we close, I'm reminded with Margaret's comments about the challenges and others' comments about challenges of change. One of my colleagues said that we need to use the 3 P's of change. One is patience, persistence, and occasionally pushy. So with those 3 P's of change in mind, I would just like to thank you all. Thank you, Margaret. Thank you, Keith. And thank you, Aaron, for a very interesting and stimulating conversation. This, as you know, will be recorded, being recorded, and will be available to the public through our website. So once again, thank you very much, and thank you to our global audience, and we hope we stay connected. Thank you.